Here's your information on the CEU hours. Nothing to disclose. And today's talk is by Dr. Bhatt, and this is on stigma and the use of language. And I think that this is something that's probably near and dear to everyone's hearts here. And I think a lot of this information may also be useful, I'm hoping, in terms of your interactions with others, perhaps colleagues or people in the community. I think that there's some information here that may come in handy. So the objectives are to appreciate that substance use disorders remain some of the most stigmatized illnesses, learn how stigma is a barrier to recovery, recognize stigmatizing language, and learn what we can do to combat stigma. So addictions, we know, are chronic diseases. It wasn't always taught this way, but I think that we've come a long way in terms of education about medical problems. These are similar to other disease states, such as hypertension, chronic disease states, diabetes, and asthma. There's many similarities. We know that the genetic impact is similar of addiction and other chronic diseases. And also the contributions of one's environment and choice are also comparable. So oftentimes we might hear someone portray addiction as sort of a moral failure, when in fact all of these things in terms of chronic disease are what play into addiction. Medication adherence and relapse rates are similar with other chronic diseases. And we also know that long-term maintenance treatment is proven most effective. So just like someone who has their diabetes under good control and medication, we're not going to suggest that they stop their insulin. The same would go for someone whose opioid use disorder is well controlled on medication. So we know, however, that there is a disparate treatment. Substance use disorders are the only conditions in which we expect people to improve their conditions before being accepted into treatment. So there's still a large part of the community where people are expected to be stable before they can actually be on medication or be in a particular rehab. Not complying or not adhering to medications are sometimes grounds for dismissal. So again, going back to that example, if someone had diabetes and their A1C, which is used as a measure of control of diabetes, was well controlled and then came out of control, that wouldn't be a reason for someone to leave treatment. So same should be for substance use. But unfortunately, there is that disparity. And withholding known life-saving treatment is actually considered in the realm of substance use disorders. So not providing medication that we know can help prevent relapse and potential overdose. Or known life-saving treatment could be rationed or withheld. So active disease for substance use disorder is often equated with criminal behavior, where you wouldn't see that with other disease states. And a patient's expected to discontinue a known effective medication, so oftentimes patients also hold that belief and may ask, how long before I'm supposed to get off of this treatment. Another disparity is with insurance. Sometimes there's no insurance coverage or limited coverage for these effective treatments. And stigma is quite prevalent. This is a slide that Dr. Bhatt got from, I believe, our site online, but it's been made by a patient who was trying to put it into visual form, their thoughts around stigma. So addiction is probably at the top, or at least among the top of the most stigmatized conditions across different societies, so in the United States and globally. Compared to other mental illnesses, people have more stigmatizing and discriminatory views towards those who struggle with substance use disorders. A study by Olson showed that people this was about 15 years ago, people in the United States, UK, Australia, thought that people with substance use disorders should indeed receive less priority in healthcare. So this study from Berry et al. In about 5 years ago, I believe the way this is separated is the blue that you see is with regards to mental illness, and the red is specific to substance use disorders. So whereas 62% of people state they would work with someone with a mental illness, 22% would say that they would work with someone who has a substance use disorder. Whereas 64% believe that employers should be able to deny employment to people affected by addiction, 25% believed that regarding those affected by mental illness. And whereas 43% oppose giving individuals with substance use disorders the same health insurance benefits granted to otherwise healthy individuals, 21% felt that way about those with mental illness. So you can see that there's quite a variety just within the field of mental illness and substance use. And following more in this study, 90% were unwilling to have a person with substance use disorder married into their family, whereas 59% with mental illness. 54% thought landlords should be able to deny housing to a person with substance use disorder. However, 15% thought that regarding those with mental illness. So there's also quite a bit of stigma in healthcare providers. This does come up in our day-to-day practice, and that was one reason for my first comment about how maybe some of this could be tools for how to approach those situations. Healthcare professionals perceived violence, manipulation, and poor motivations as some of the factors that impeded healthcare delivery to people with substance use disorders. What we've seen is in learning that this is also problematic, that psychiatry resident attitudes towards patients with substance use disorders actually worsen through the course of their training. And part of that might be due to how we teach, and part of it may be sort of our subconscious, how we're modeling that for our residents. And what another study found was regard for working with patients with alcohol or other drug use disorders was across the board lower than regard for working with those with depression or diabetes. And primary care providers in general seem to show a lower regard than other professions, which I find surprising, Dr.
Me too.
I have to say I find that surprising. I'm not sure.
I do as
well. So let's talk just for a moment about language. So here's another one of those slides that is depicting kind of how our language impacts our worldview. So there's two commonly used terms. So referring to someone as a substance abuser implies that it's their fault, so that they could actually change that, so that it's willful. Whereas having a substance use disorder is more person-centric, right? It implies a medical malfunction, so something that's not their fault, it's not something that they can help. Does it really matter how we refer to people with highly stigmatized conditions? So are we just sort of like making something into being politically correct? You'll see that actually there's been quite, I can't quite see the top label here, sorry, but Snehal, do you want to talk to this slide? That might.
Yes, Snehal here. I certainly can. So this is a study where two groups of people were given the same exact vignette about a person, except one group read about a substance abuser and the other group read about someone with a substance use disorder. That's the only thing that was changed. Everything else was the same. I think the two most striking things for me are just based on that. The group that read about the substance abuser, was significantly more likely to think that the person needed to be sort of, incarcerated or receive kind of legal, I guess, ramifications, as opposed to if they read about someone with a substance use disorder, they were a lot more likely to think that the person actually needed treatment.
And we know that stigma worsens outcomes. So self-stigma, so when people are internalizing that public face of that stigma, feeling shame and guilt, low self-esteem, low feeling of self-efficacy, that sort of why try effect. So why should I even try to have a better quality of life? This is sort of learned helplessness, demoralization and feelings of inadequacy. And so one study looked at perceived stigma among patients and found that these patients experienced a significant level of discrimination. So 60% believe that people treated them unfairly because of knowledge about their substance use, and this comes up quite a bit in terms of patients talking about how they really don't want to go see other providers, let's say, because of this experience or concern about such an experience. Feeling feared, so 46% felt others were afraid of them when they found out about their substance use. And feeling abandoned, 45% felt that their family gave up on them after finding out about their substance use. And what do we know about the connection between stigma and treatment? So patients who struggle with addiction are less likely to seek help or treatment because of this perceived stigma being so high. They report high discrimination, they feel feared and abandoned. And they're more likely to drop out of treatment due to stigma when they start. And then for healthcare professionals, this has also been studied and shows that in general, in healthcare, professionals hold patients with substance use disorder in poor regard relative to other patients, seeing them as less motivated, potentially violent and manipulative, and they may avoid these patients, or shorten visits, and this in total leads to suboptimal care. This study, a large study, looking at 34,000 people with alcohol use disorder across the country, showed that treatment utilization was highest in the patients identifying lowest stigma. Individuals with a lifetime alcohol use disorder were less likely to use services if they had a higher perception of stigma toward individuals with alcohol use disorder. And odds of treatment, self-help decrease with each increase in alcohol stigma quartile. So there was a direct relationship there. Another study found that perceived discrimination also led to dropout from treatment. And we know that outcomes are worsened. So components of recovery, their overall health, feeling of home, purpose, community, and hope. And stigma was equal, essentially, to worse outcomes. So they were less likely to seek and stay in treatment, experienced worse mental health outcomes, worse physical health, decreased employment, more unstable housing, a general breakdown of their social support systems, and worse outcomes related to their substance use disorder linked to the experiences of stigma. So what can we do here in our last 5 minutes talking? So I think this, again, is something that all of you certainly do every day. We treat people affected by addiction with the same respect that we treat all of our patients. Learning about the science of mental health conditions. Sometimes I think having like an article on hand or a resource to kind of bring into a conversation when this comes up, perhaps with colleagues or students, and pointing out to others who have misconceptions about substance use disorders and mental illness. in the community at large, we can help address stigma by supporting resources for people who are affected by mental illness and education. So appreciating that most people with substance use disorder make recovery with treatment and lead productive lives, and making sure that we are bringing a voice to this and informing others. And then we can be a personal witness, so putting a face and a voice on recovery, much in the same way, talking about how essentially our careers, we are witnesses to this in our careers. And then changing our language and terminology. Again, sometimes it feels like we're just pointing out very specific details in language. This comes up a lot with our learners. I think one example that comes up in the clinic at large, for instance, saying if someone's clean and reframing that language, talking about someone, say, having a negative urine tox result. So just constantly making that part of our language and educating others. We can continue to advocate for our patients and help create accepting and patient-centered environments, working within the community to help combat stigma. Other ways are working with tribal, state, and national leadership to enact policies to benefit communities. So this might be things such as funding for treatment, drug take-back programs, education aimed at community members, and engaging youth. This slide is going back to that language point. On the left is a column of what would be considered more stigmatizing language, and on the right would be the language to reframe that and make it more person-centric and consistent with really all medical illnesses, so that we're not promoting any of that stigma. So for instance, rather than referring to someone as an addict, referring to that person as a person with a substance use disorder. Partway down, you can see, for instance, the references to urine results or just recovery in general, saying clean or dirty. Ways to talk about those might be testing positive for substance or for a drug abuser, a person who uses drugs. So most of this is really just remembering that person-centric language, making test results more objective can help. This is an anti-stigma toolkit that can be quite helpful, and wanted to open it up at this point to any of your questions or comments from your experiences. And you can go ahead, and we have about, I think, 3 more minutes before we were